We lose almost an entire med school class every single year to suicide. 300 to 400 physicians die per year, roughly, of suicide, and probably countless more where we just don't even know. It's not recorded as a suicide. If they die, that is 100% the responsibility and the liability of the insurance company, because there's absolutely no reason they should be cutting funding to clinics, to physicians, to healthcare providers when they're making billions of dollars of profit. It's not about my paycheck, it's about my patients getting the care that they deserve.
Dr. Brittany Albright is a Harvard-trained psychiatrist and public health expert who's on a mission to change the way that we view mental health.
No amount of Prozac is going to negate all of the trauma that we do to our bodies, to our souls, to our minds, and we have to start changing the way we live.
Welcome to the MedStory Podcast, where we have real conversations with leading voices in healthcare. No fluff, no hype, just honest stories, bold ideas, and tough topics that deserve more attention. If you're tired of surface-level health talk and want deeper insight from the people actually doing the work, you're in the right place. Do us a favor, rate, subscribe, and stick around.
So tell me, why are physicians at higher risk for suicide than the rest of the public?
That's a great question, Spencer, and it's something that bothers me deeply because the reality is that we lose almost an entire med school class every single year to suicide. So not only is it devastating on an individual level for a family to lose a loved one and for a community to lose a great doctor, but it's also devastating to society as a whole because we invest so many resources financially, educationally to train up excellent physicians. And so this has massive public health consequences to our entire nation. And one thing that is especially bothersome to me is that the suicide rates among female physicians are astronomically higher than females in general in society. And so we are doing something wrong, and we do need aggressive intervention to reduce the suicides. Around 300 to 400 physicians die per year, roughly, of suicide, and probably countless more where we just don't even know. It's not recorded as a suicide. Personally lost one of my colleagues from medical school to suicide. And so that's why this is a very, very important issue to me personally as well.
That makes sense. For me, as someone who's listening to this, say, like, that doesn't make sense. A physician is probably the highest, most respected job you can get, and it pays well. So why would a job like that actually have a higher suicide rate?
There's so many factors that play into suicide and particularly mental illness. And not everyone that dies by suicide has mental illness. However, the vast majority of individuals that die by suicide, there often is a history of mental illness. And the factors that I see are, it's hard as physicians to access treatment when we suffer from mental health issues. There's unfortunately still a lot of stigma against mental illness, and particularly within the medical community. For example, every year when I'm applying for my malpractice insurance, when I'm reapplying for my state medical license, for my board certification, we have to check a box to state if we have a history of mental illness or not, or a history of substance abuse or not. And if we check that box, we might be denied malpractice insurance. We may be denied credentialing for insurance panels. We may be denied a promotion. And so we have to hide in the shadows and not seek treatment. And we all know that mental illness, particularly depression, is pervasive in society. And therefore, we're not spared as physicians. I know myself personally, I have suffered from anxiety throughout my life course. And it's hard to seek treatment when you fear that there could be negative consequences, particularly in your career. That's actually one small facet of it. The other facet is, I really appreciate, Spencer, you said that we're one of the most highly regarded professions and well respected. And Unfortunately, that's changed actually quite a bit in the last 10 years. And there's been surveys of patients that it reveals that a lot of individuals mistrust physicians. And so much of it has to do with our healthcare costs in this country rising. And it's often easy to blame money-hungry doctors, right? Sure, you're correct that we make an amazing salary. I say all the time, I cannot believe I get paid and paid so well to hang out with and speak with people all day that I would be friends with if they weren't my patients. I truly feel like I have the best job in the world. But the reality is it came at a huge cost. All of us go to school for a minimum of 12 years beyond high school. That results in 12 years of very minimal income, often no income for the majority of the years. And I know you're a physical therapist, Spencer, so I know you understand too, because you had a long educational journey yourself. And the problem is, not only are we not earning an income during that time period, but we're going into substantial catastrophic debt. I know many of my friends and colleagues that are well over $500,000 in debt. I know when I went to medical school, the interest rates were near 7% for my personal student loans. My husband and I had to pay off our loans. It took us over a decade. Our loans combined, and he didn't go to medical school, his was other educational loans. We were paying over $2,000 a month for over a decade. Well, in the old days, that used to be a mortgage. Now it's not so much, but back then it felt like a mortgage. So there's the financial stress compounded with the academic stress we endured, compounded with a lot of individuals, unfortunately, do not respect us in society and respect our profession. There's the fact that we feel like we can't seek treatment for our own mental health issues. And then lastly, our jobs are really, really hard. They're so hard. And we are constantly under threat of liability, lawsuits. We constantly fear making mistakes. It's impossible to not bring our work home with us. We're expected to work, especially during residency, up to 80 hours a week and even more, I would say, especially depending on the specialty individuals choose. And then when we do get our job, finally, the job we've worked 12 plus years for, it's often disenfranchising because we're not allowed to practice the way we want to. We are told how to practice. 30 to 40 patients may end up on our schedules. We can't provide the great care we've been trained to do due to time limitations. Therefore, we feel demoralized because we're not treating patients the way that we feel they deserve. We are burdened with portal message after portal message after portal message, email after email after email, and we can't keep up. Physicians will stay up till midnight very commonly to try to get their work done, and it's still not done. And that's time we're not compensated for. So we are paid extremely well, but most of us are also working the equivalent of 2 to 3 jobs when you factor in all the hours we put in and all the uncompensated time. That's why physician suicides are astronomically higher than they should be. In fact, there should be not one suicide because we cannot afford to lose any physicians.
I agree with everything that you're saying right here. And I find that the irony in this is that you've gone to school for this long, and with one real goal is to get people healthier so that they can live longer and better lives, right? But you've trained this long. However, the culture that you've worked yourself into is actually very unhealthy. Right?
Very unhealthy.
And so it's these two ends of the sword there where you're like, here I am telling these people to be healthy, but am I actually following that up with my own lifestyle as well? And unfortunately, with a lot of physicians, I don't think that that's true.
We don't practice what we preach, Spencer. Most of us don't. Most of us can't afford to.
And that's where I'm excited to have these kind of conversations with people like you, because I think that needs to change. It has to change because people don't realize the evolution that's happening in healthcare and the squeeze that's happening as far as, decreasing reimbursement rates, increasing burnout. And people don't understand that eventually that's really going to significantly impact patient care as well. Right. And so we need to have these conversations and start making changes now before it's too late.
I'm glad you highlighted the reimbursement rates too. It's public knowledge that every year Medicare has been attempting to cut physician reimbursement rates. And that's devastating to our medical community as a whole, because it's physician reimbursement rates, nurse practitioners, physician assistants. I want to include all of them as well, because they are our wonderful colleagues and they help us, they support us. They also do the mission of patient care and often very well. And so I want to encompass all providers. I want to encompass physical therapists too. Everyone is needed, and every single field, not just physicians, got cuts in their reimbursement rates, which seems like a good idea in theory to conserve costs for our nation. But then people don't understand, with inflation at historic astronomical levels, how are we supposed to pay our administrative staff? How are we supposed to pay the person that answers your phone call at 10 p.m.? How are we supposed to pay our employees' health insurance premiums that continue to rise? How are we supposed to pay the lease on our office space that continues to rise? That's the problem. The reimbursement rates we get as providers, that goes to pay for all the support staff. Mm-hmm. The person who does the medication prior authorization, for example, so that patients can actually pick up their medication from the pharmacy, it has such downstream consequences. And as a result, a lot of medical practices, especially private medical practices, that are still able to provide that good one-on-one patient care and a great service, they're closing because they can't afford to stay open anymore. So not only are we losing our physicians to suicide, we're also losing them to our system and our economy, and they can't afford to stay open anymore.
This is one of the reasons I was so excited to talk to you, because not only you're a psychiatrist, but then you do have your master's in public health too, right? That's correct?
That's correct.
Yeah.
And I almost think that it should be required education for physicians, for medical students before they start medical school, because it really gave me a framework of looking at issues on a societal and population health level and not just an individual patient level, because that's the only way that our systems are going to change, is if physicians, healthcare providers themselves are educated on these issues, and leaders in the country, to be honest, because a lot of decisions are being made without our input. And so it's our job, our role to get involved. And I think that's also the only way we're going to see a decrease in physician suicides.
For sure. So just so people can understand why the squeeze is happening and the reimbursement rate, I think it is important that they understand that in the 80s, maybe the 90s, it was kind of the Wild West of billing, where it was a fee for service, and then pretty much healthcare providers shot themselves in the foot, because unfortunately there were some that overcharged. Yes. And then so the insurance company said, okay, we need to figure this out. And what people need to understand is that Medicare as a whole is a government entity, and it has a certain budget that it has to stick to, right? And with that budget, they've said, okay, we're going to transition to more of a value-based model where you need to show us the value that you're providing. And with that, it makes sense. You're like, okay, that makes sense. You should get paid for the value. However, that came with a lot more administrative burden, where, okay, now we need to fill out these more forms, we need to do more documentations to justify the value that we're offering. And so what has happened is that we have had to bring on more administrators to support that, like you're talking about, for pre-authorization, follow-ups, all those things. And so we're taking the same budget, but we're distributing it between more people. And so something had to give there. That was my understanding. Do you have the same take on that?
Exactly. We have to find a way to cut costs for healthcare in this country. We spend by far the most per capita in this country than any other Western nation. And yet our healthcare outcomes are significantly worse. We have a huge problem. And there's so many reasons as to why that is the case. A major problem is also the way we reimburse. Like you said, that procedures reimburse very well historically versus actually spending time with the patient, spending 30 minutes. I often spend 40 minutes with my patients. That is, I get paid half the amount per the time I spend if I spend 40 minutes with patients versus a 15-minute med check. To me, that's worth it, and I find ways to make it work financially, but most doctors don't have that privilege. And it takes time to really counsel patients one-on-one, hear their values, hear their concerns, and work with them on a plan to get them well, which is called shared decision making. That takes time. Good care, good medicine takes time. And you know so well, again, as a physical therapist, it doesn't happen overnight. You have to see people repetitively. You have to support them. You have to figure out their barriers. It just takes time. But the problem is we're not compensated for that. And so therefore, we just send a lot of referrals. We just do quick procedures. Let's put a Band-Aid on this, knowing that patients are going to have to come back. And that needs to stop. The way we reimburse our clinicians needs change. In addition to that, there's unfortunately our health insurance model, which is the best that we have at this point, but that's not working either. One example is last year I got an email from United that they were going to significantly cut our reimbursement rates as a practice. No reason why, no justification. It was just, this is the new contract. We're having everyone in the state sign this, so you need to sign this. And I would not agree to sign that, especially as I read a news article that United Healthcare was seeing historic multi-billion-dollar profit at that very same month. And so I would not accept that. And so I spent weeks with back and forth emails, negotiating, and I had to tell the rep that as a result of these budget cuts, I'm not going to be able to treat their patients anymore, and that they're going to have to find another psychiatrist for these hundreds of patients. And if that results in worse outcomes for my patients, if they attempt suicide, if they end up in the hospital, if they die by suicide, that is 100% the responsibility and the liability of the insurance company, because there's absolutely no reason they should be cutting funding to clinics, to physicians, to healthcare providers when they're making billions of dollars of profit.
You are firing me up right now, because I think it's like so true, because the truth is that you're not the only one that got that letter, right? And some providers just said, okay, I guess that's what I have to do. And they accept it, right? And then what they don't understand is you are hurting you're hurting the profession, but you're also end up hurting the patient by accepting those terms.
Exactly.
Right?
And at the end of the day, that's why we're here. That's why we went to school for so many years, or at least I can speak for myself. I'm here for the patients. And so that's why I'm fired up. It's not about my paycheck. It's about my patients getting the care that they deserve.
Wow, it's amazing. It really is. So as a business owner, because you now have psychiatrists working for you, correct? How did you manage that kind of stuff?
And that's also why I advocate too. It's not just for my patients. It's also for the providers that I care so deeply about. One of the reasons I started my own private practice was because as a woman, and especially as a mom with young children, the system would not accommodate me. I want to be able to show up for my kids. I want to be at their school performances. I want to be at their parent-teacher conferences. I want to be able to pick them up from school. I want to be able to drop them off. That's not acceptable in most healthcare systems. You have to work from 8 a.m. until 6 p.m. and then you have to finish up your documentation and notes and call patients back at night. That's a very standard schedule for most physicians in this country. We deserve something different. We deserve to be good moms. Our children deserve to have good parents that are involved and that are engaged. And so that's why I started my practice. And I wanted to provide a space where, especially female physicians that are moms, that they can set their own terms, that they can work the hours they want to. If they need to cancel a day because their child is sick, no questions are asked. We do that automatically and make sure that the patients are seen at a reasonable time by someone else if necessary. I also wanted to make sure that our physicians, our nurse practitioners, our physician assistants had the freedom and the autonomy to spend as much time as they wanted with patients. They can see patients as frequently as they need to. Part of the reason I think our outcomes are so good at my practice is because I see a lot of my patients every single week if that's what they need. That's expensive, of course, to our healthcare system to see select patients every single week. It's actually not, though, because my hospitalization rates for my patients is astronomically low. And it's because they get the time that they need. If they have an emergency or a crisis, I'm there for them. I can typically see them within a day or two. They can access me on the portal, and I budget time in my schedule to check those messages. And that's how healthcare in this country should be. Somehow I'm making it financially work. We're not making a massive profit, but we all have joy in our work, and we all feel like we're contributing positively, not only to our community, but to our patients individually.
It's a very fine balance that you're riding right now with focusing. Of course, you want quality care first, and that's leading to better outcomes. But of course, you got to keep your doors open as well, right? And so that's where provider and entrepreneur comes together. And that's where the challenge, but also the beauty of it is, because you got to get creative of the ways that you're going to make it work, right?
Exactly. One thing I was taught in my master's degree in public health was, with a healthcare system, you can't have it all. And the three elements are quality, cost control, and accessibility. And I love it when people tell me I can't do something, because I'm always going to try at least attempt to prove them wrong. And so that's the thing I'm most proud of about my practice, is that I feel like we do a very good job of offering accessible care. We can always get patients in within a week, sometimes 2 weeks, including new patients. Not only that, it's affordable for our patients. We take commercial insurance, we take TRICARE, we take Medicare. And then lastly, we provide really quality care. And so I've proven my professors wrong, and I'm very proud of that.
That's amazing. That's amazing. And the one thing I do want to touch on is that you talked about your hospitalization rates, right? And so what insurance companies have started to realize is that when patients go to the hospital, it's super expensive. And so
expensive.
They're trying to figure out what are ways that we can keep them out of the hospital. So there's many ways that they do that. For example, they're looking at, so once a patient leaves the hospital, they look at something called rehospitalization rates, and then they judge your criteria based on that. And then, but that also before the fact as well, is being like, can we keep our patients out of the hospital? And, I may be biased, but if there is two professionals that they should be seeing, it's someone for their mental health and someone for their physical health, right? And being a psychiatrist, me being a physical therapist, right? These are things that should be definitely seen as preventative services, but worth the investment.
Exactly. And that's where preventive care comes into place. We try to get our patients in very early, before they get to the point of having to wait 3 months, 6 months, sometimes 9 months, especially for child psychiatry, to be seen. While they're waiting to be seen, their symptoms get worse and worse and worse. But if they call our office, we can see them in a week. We can get them set up with psychotherapy, and we can start them on medications if necessary right away. And we can follow up with them weekly to make sure that they're improving. We also do rating scales. And so we can see when someone is in a more moderate to severe range and provide more aggressive interventions early on versus someone who's just starting to have symptoms. And then we can, of course, treat them early on as well. So that's part of it, is recognizing signs and symptoms, doing rating scales because it's often hard for patients to disclose exactly how they're feeling, talking with family members, and then again, spending time with them to not only give them a medication if necessary, but to actually talk about the real stuff that we know that works in psychiatry, which is healthy diet, low inflammatory, healthy, fresh foods, and using motivational interviewing to figure out what are their barriers to accessing healthy foods. It's talking about exercise. And I'm sure, gosh, Spencer, you can tell me all day about how challenging it is to get someone to exercise. But we want to work with them and again, spend as much time as we need to help them to overcome those barriers. Another major issue is sleep. So we spend a lot of time discussing sleep with our patients. To me, sleep is the most important vital sign in psychiatry. If sleep is impaired, nothing is going to function well. And so if I can get sleep under good control, I can get all symptoms under better control. Another component is social connectedness. If my patients are isolating themselves at home, working remotely all day on a screen, and then they're on social media, doom scrolling all night, they're not going to get better. And so we set a goal of try to reach out to 2 people every single day and have that personal connection. Lastly, nature. I want my patients to be outside. I want them to be enjoying the beauty of nature. There's so many mental health benefits to nature that I won't go into all of them now. But all of those elements need to be in place. And so that's what we focus on, not just medication, not just what happened to you as a child. Those are important too, but they're, in my opinion, a smaller piece of the puzzle than all the lifestyle interventions that we need in place. And now I do have patients that are doing their best and they've tried all these interventions and they're still struggling with depression, for example, or anxiety, or bipolar disorder, or a substance use disorder. We know that mental health issues are extremely genetic. And so despite many of my patients' best efforts, sometimes they need a little bit more help. And enter in interventional psychiatry. I never planned on being an interventional psychiatrist. I'm actually an addiction psychiatrist by training. But I just realized that the interventions I was taught were not enough. I still had patients not getting better. And so, thank goodness, over the last 10, 15 years, interventional psychiatry has become more standardized. It's become reimbursed by insurance companies. It's become more accepted. And so the beauty of being in a private practice is I can pivot and add an intervention next week if I want to, if I feel like that serves the best interests of my patients. And so, honestly, I credit having interventional psychiatry as a part of my practice to our outcomes.
Tell me, what's the difference between like a normal psychiatrist and interventional psychiatry?
Great question, Spencer. I think we should all be interventional psychiatrists at the end of the day because research has shown that treatments such as transcranial magnetic stimulation, such as S-ketamine, such as ketamine, are significantly more effective than standard medications and standard psychotherapy, even though I still believe and advocate for all treatment modalities. And therefore, the arsenal we've been given for the last several decades, it's just not working.
For sure.
So many patients, in particular with major depression, are not getting well from our standard medications. And so therefore, I feel interventional psychiatry should be the standard of care and should be required and necessary as part of our training.
I want to dive into all of these things, but let me take a step back. So tell me, let's focus just starting on depression. What is something about depression that most people don't know about?
It's interesting. I would say the one thing that people don't know most about depression is that we don't know much about depression as a field. It's fascinating. As psychiatrists, we rely on the DSM book. That is our Bible in psychiatry. And I joke all the time that I would not want to be part of a religion that is constantly shifting and changing and that's not based on really much science or much fact. It's more of a history of where we've been in psychiatry. And so all the DSM is really a cluster of symptoms, a grouping of symptoms, and then we label it as a diagnosis.
Mm-hmm.
The reality is with depression, there's no correlation between brain chemistry, brain physiology, brain anatomy, and this thing that we call depression. We can see well over 200 different phenotypes of depression. And the inter-rater reliability of diagnosing depression among healthcare professionals is extremely poor. That you and I could see the exact same patient and come up with completely different diagnoses. And so our system is not very good. And to me, that's what's so shocking about this thing that we call depression, is that we don't know what exactly causes it. And the best that we have is this biopsychosocial spiritual model and all of these factors at play that contribute to what we believe is called depression. I'm very fortunate to supervise psychiatry residents at our local university. And I was talking with them a couple weeks ago, and I asked them, so what even causes depression? What is depression? And they said, well, we were taught that it's a deficiency in neurotransmitters like serotonin, norepinephrine, dopamine. And in my head, I'm like, that's really cute. That's what I learned, gosh, almost 20 years ago. And that's not the correct understanding. And so part of the issue is that our curriculum is not being updated. And actually, I was talking with one of my colleagues via email. His name is Dr. Vladimir Malatek. And we were just complaining about how outdated curricula is in these medical schools and in these training programs. And the reality is that we're thinking more and more that depression, mental illness is caused by inflammation in the body. We're looking at different neurotransmitters such as glutamate as a main cause potentially. We're looking at synapses and the lack of connectivity, the lack of communication, the lack of healthy brain networks. We're looking at trauma. And of course, all of that contributes to inflammation. And so that's why lifestyle changes are so important, because no amount of Prozac is going to negate all of the trauma that we do to our bodies, to our souls, to our minds. And we have to start changing the way we live.
100%. And I think there's a bunch of ways to do that, because this is that's interesting. What I was imagining that you were going to tell me is that there's a very clear depression or definition for depression, and it is a clear decrease in dopamine and serotonin, right? And I guess that's not the case. But then we can go, okay, that's not the case. We're understanding there's so many factors of a lot that we don't understand within the brain. However, some things that we do understand is we can look culturally and compare country to country based on happiness and depression levels. And the US has the biggest economy in the world. However, rates really low when it comes to the happiness scale. So have you ever looked at other healthcare systems or countries maybe like Finland or Norway that typically rate really high, and maybe there's something we can take from their playbook?
Oh, there's so much that we can take from the playbook of other countries and other cultures. And I'm very fortunate that I got to do a study abroad working with the National Health Service in London and learning about a universal healthcare system and what does that look like. There's so many benefits, undoubtedly, to a universal healthcare system. The problem is that as all these countries adopt American habits and American lifestyles, and our economy spreads throughout the world, which in many ways is a wonderful thing, we're also seeing our health outcomes spread to other countries, and particularly underdeveloped or developing countries too. Unfortunately, we're starting to see their health outcomes declining as they accept our restaurants and our quick, fast-paced lifestyle. And there's so many reasons why many countries do so much better than we do. And a lot of it comes down to their work-life balance, how their middle class is larger than ours, so they can afford more resources to exercise, to eat healthier. Also, just go to restaurants in a lot of these countries. I was amazed being in Spain and Portugal last year and just seeing healthy, fresh food on the table. Their food just tasted so much differently. And how many holidays they have a year, how their education is free, how their colleges are either free or significantly lower cost than ours, which allows them the freedom to spend their resources on other things in their life and in society, just the slower pace. But at the end of the day, it comes down to socioeconomics. It comes down to poverty often breeds worse health outcomes. And unfortunately, in our country, we continue to have a catastrophic issue with poverty and lack of resources to those who need it most.
Absolutely. Yeah. I also am someone that I love to travel. I've been fortunate to, I've studied in Scotland. I went and learned Spanish down in Colombia for a few months, and going to see these different cultures, it really opens your eyes, because you think like, oh, we're in the US, like we have all of the stuff. We must have the best life possible. And then you go and you travel and you're like, wait a minute, what were we missing out on? Because there's so many things like that, like you talk about the fresh food, and it's not, yes, there's poverty, but I've seen people with a lot less that are a lot happier as well. So a lot of it is perspective as well, for sure.
I'm glad you highlighted that, because it really does come down to perspective and connectedness too. It's one thing I think everyone should be doing in their lives and raising their children to do is service work, and particularly mission work abroad. I'm so fortunate that I grew up going to very low income areas of Mexico throughout all of high school. And that bred in me a desire to continue to serve. And so I got to participate in different medical mission trips in Honduras over the years. And
Amazing.
you are absolutely correct. The most astounding thing I learned as a freshman in high school, we were building homes for individuals that basically had no home. They were living essentially in shacks. And so we came in to build cement, sturdy, well framed out homes for them with stable roofs. And they were so grateful. They were in tears and hugging us by the end of the week. And I'm just getting chills thinking about it, that we even had individuals on almost all of our mission trips where the families would make us food on the last day. They would try to feed us sandwiches. And here they are with almost no resources, and they are wanting to give back to us. And it was just such a humbling experience. And I just loved seeing their culture, seeing the joy, seeing their connectedness. And it really taught me we don't need any of this. That actually, I shouldn't say that. There are some comforts that make life easier. But at the end of the day, we can have joy, we can have wellness without all of the stress that comes with our westernized country.
Oh, I could talk to you about this for hours. And I think that if we were to touch on two of the most biggest things that I think that you touched on were, I personally have worked with a lot of people who are on their last phase of their life. And I have seen a clear dichotomy between, there's the ones that have a lot of money, but they live in their house and they're by themselves. And then there's those who, whether or not they have money, they're still connected with some sort of community, right? And it's very clear. The ones that have community, the ones that are staying participated with humans, human-to-human connection is therapeutic, whether I like to believe it or not. And that should start to be in our treatment programs. Not just, here's your medication, do this exercise, but just go hang out with the people that you care about, give back, and the benefits are so immensely huge.
So tremendous. And I'm glad you alluded to that, because I was so fortunate that my psychotherapy professor during my Harvard psychiatry residency, his name is Dr. Bob Waldiger, and he is amazing. He is in charge of the Harvard Happiness Project. And this is a research study that started, gosh, I believe it was over 100 years ago or almost 100 years ago. And they took male students at Harvard and they followed them over decades. And then eventually they folded in their wives, and they folded in individuals from lower income areas within Boston. And they studied all of them to see what creates happiness. And the results were astounding and very apparent. And it was exactly what you said, Spencer. Happiness is 100% correlated with our social connectedness and the quality of our relationships. Not even just happiness, longevity too. And so why is that not our main intervention in medicine, in psychiatry? It needs to be.
It really does. It really does. Oh, I would love to dive into all of these so much deeper with you. I know I want to be mindful of your time because I know that you have other meetings, and then you're going on a Disney cruise later with your kids today that you're gonna surprise them with, which I think is so cool. I'm excited to hear how that goes. But so if
money can't buy happiness, but it can buy a Disney cruise, I will say. And that if you're not happy on a Disney cruise, then we need to start doing shock therapy, I think.
Oh my God, that's amazing. That's amazing. So for someone that maybe was listening to this, and if they want to learn more about you or potentially see even one of your staff, something like that, where could they learn more about you?
Yeah, so I practice in the great state of South Carolina. And so my practice is called Sweetgrass Psychiatry. And we're fortunate that we can treat any resident in the state of South Carolina, no matter what county or town they're in. We're happy to treat everyone. And I'm very passionate about all these topics about public health. And so I'm also working closely with an organization called Psych Congress. And I'm very fortunate that they allow me to give talks a few times a year. So that's just a plug for Psych Congress. Come to one of our conferences. And then I also use LinkedIn almost as my personal therapy and way to process what I see in my career, what I experience in life. And so I would love to make more friends on LinkedIn and to hear your personal stories and your journeys and your struggle as well.
Amazing. Amazing. Well, Dr. Albright, I appreciate you spending the time to kind of talk about all this stuff. And hopefully this is the first of many where we can hop on and kind of talk about these things.
Thank you so much. And I appreciate you being passionate about the same topics I am.
You've been listening to the MedStory Podcast, where we dive deep into the stories that shape medicine and healthcare. If you found this episode insightful, be sure to follow, rate, and review. Your support helps us bring more valuable conversations to the forefront. This has been a MedStory Studios production, where storytelling meets medicine. Until next time, stay informed, stay inspired, and keep pushing the boundaries of what's possible in healthcare.